Welcome to Obesity, a Disease, the official Obesity Medicine Association podcast exploring the many facets of the disease of obesity. In this episode, we'll be hearing from obesity medicine specialist and OMA clinical education director, Dr. Nicholas Pennings. He'll be interviewing Angela Fitch, MD. Dr. Fitch is co-director of the Massachusetts General Hospital Weight Center and faculty at Harvard Medical School. She is the president-elect of the OMA and presented at the 2021 OMA Fall Obesity Summit. Today, our speakers discuss the benefits of combining different modalities of therapy for optimal obesity management and how traditional therapies can be better together, according to Dr. Fitch. Obesity, a Disease podcast is brought to you by the Obesity Medical Association, the clinical leader in obesity medicine.
Synergy, when the interaction between two or more things produces an effect greater than the individual parts. We see synergy in nature, we see it in the workplace, we see synergy in medications used to treat many conditions, including pain, blood pressure, and infections. For pain management, we combine medications like acetaminophen and ibuprofen or add select seizure medications and antidepressants. Additional modalities such as procedural interventions or physical therapy will enhance therapeutic effect. So why shouldn't the same concept apply to treating patients with obesity? We're already seeing combination anti-obesity medications like phentermine, topiramate, or bupropion, naltrexone approved by the FDA with more in the pipeline. Is this just the tip of the iceberg? Hi, I'm Dr. Nick Pennings, Chair of Family Medicine, the Campbell University School of Osteopathic Medicine, and OMA Clinical Education Director. And I'd like to welcome Angela Fitch, MD, to the podcast. Dr. Fitch is the co-director of the Massachusetts General Hospital Weight Center and faculty at Harvard Medical School. She is the president-elect of the OMA. Dr. Fitch presented at the 2021 OMA Fall Obesity Summit. Her presentation was titled Better Together, Combination Therapy for Optimal Obesity Management. Welcome, Angela.
Thank you, Nick. It's great to be here.
Nice to have you here. So, one of the things that we find that there are so many choices for clinicians now to help manage patients with their weight than there was just a decade ago. And while this is a welcome thing, we now have different dietary interventions, different medications, different behavioral therapies, devices, endoscopic procedures, surgical procedures. How do you decide which path to take?
I think that's an excellent question, Nick. And I think one of my passions in obesity treatment is really to work on promoting shared decision-making in treatment, right? So the idea of shared decision-making is not new, although I think in obesity, we sometimes, for whatever reason, clinicians don't address it in the same way they would other types of treatments like heart disease, and you might have a shared decision discussion with someone if they're going to have angioplasty or if they're going to have open heart surgery. There may be different options for patients to choose from. And they choose those options based on their own personal desires, personal preferences, goals of treatment, goals for their lifetime, personal or beliefs, in what treatments might be the most efficacious for them, right? And so I think, to look at what the treatment options are and look at what the patient's goals are, right? And then to try to match those goals with the treatment options is really what we do every day. And I think what patients really appreciate, because we need to level set expectations of treatment outcomes as well.
I think that's such a great point because it's so important that we engage the patient in the decision-making process. We tend to be taught to be directive, take this antibiotic, take this blood pressure med, right? And that's kind of the training that we have that, we're the authority and we need to tell the patients what to do. But I think it's so important to engage the patient in that, because the patient needs to make decisions all day, every day about lifestyle changes, right? They're always having to decide what to eat, when to eat, and how much to eat.
Yes, and same with any lifestyle intervention, sleep, stress, activity. We have to make these choices when we're choosing lots of things every day, right? I mean, what we're going to wear, there's lots of choices we make every day. And in medicine in particular, I think, especially obesity treatment, we have to align those patient goals for their outcomes with the expected treatment result from the intervention. Mm-hmm. But patients, because obesity is so stigmatized and there's so much bias and stigma, even in the individual person, because of society, because of the world, I think we have to reset that for patients and say, if you have a BMI of 45 and you need to get your BMI to 35 because you need a kidney transplant and you need to get there, what treatment option is going to get you there best? And that might be not just one option, right? That might need a combination treatment, much like a blood pressure of 165 over 100 probably needs more than one type of treatment, to get a patient down to their goal of 120 over 70.
So as you're working with people, and instead of taking that just a directive approach, we need to do more of a guiding and following kind of approach, and guide that patient through that decision-making process. So what characteristics do you look for in patients to help you guide a patient toward a certain treatment plan?
Yes, I think it's very important. One of the things I think are challenging in obesity treatment and challenging in what is a patient's expectation of the world, right? I mean, this is dictated by society, unlike a lot of other treatments in medicine. So if you ask 10 people on the street, how do we treat breast cancer? I would venture to say that most people would say surgery, radiation, chemotherapy, not go out and eat more vegetables, for example. I mean, that's important to breast cancer treatment to eat vegetables. We know that, but it's not the mainstay of treatment. Yet if you go out and ask 10 people on the street, how would you effectively treat obesity as a disease, which is the title of our podcast? I would say a lot of people would say, oh, you eat less and exercise more, which is what we know in studies. If you're looking for that 20% weight loss, which is getting your BMI from 45 down to 35, that's a greater than 20% weight loss that's necessary to do that. If you're looking for that level of efficacy of treatment intervention, that is only produced by lifestyle intervention less than 10% of the time. So there's less than a 10% chance for that patient to be able to do that. Now, when I present that to patients, when they say to me, I tried Weight Watchers, I tried this, I haven't been successful, they feel like a failure, like somehow they're substandard of a human being, right? Because they weren't successful with that 20% weight loss, with that intervention. And when I tell them only 10% of people can do that, it's like their eyes light up and they go, really? I thought everybody did that. I thought everybody lost 50 pounds when they're 250 pounds, right? I thought everybody could lose that 50 pounds with their Weight Watchers, because that's what they see on the TV, everywhere.
And I think that's where those testimonials can be so harmful, because they create these unrealistic expectations. The idea that weight loss should be easy, and if it's not easy for you, what's wrong with you?
Exactly. And as we educate people in that expectation, we then have to say, well, if you really need to get to this BMI of 35, for example, and I know BMI is not the ultimate thing, goal that we should be even targeting for something like candidacy for transplant, but that's a fact of life right now. And, if we have to get a patient to that goal for whatever reason, we have to say to the patient, well, this is your likelihood of doing that with this treatment option. So here are the risks and benefit of each of those options, right? Because some patients might say, for example, for a greater than 20% weight loss, we know that 40% of people are able to do that with semaglutide 2.4 milligrams today with the new data that's come out. So 40% of patients can get greater than 20% weight loss. But a patient might say, that's great, I'm going to give that a try. But maybe a patient says, I don't really want to take another medication. I take 20 medications already, and I really don't want another medication. What other option do I have? And then you have a bariatric surgery, which produces a greater than 20% weight loss in about 80% of people. So now you've doubled your odds of getting into that 20% category with that treatment intervention. And again, maybe that's what that matches and aligns with that patient, that they don't have to take another medication and they're going to get off these others, right? And then get to their goal and get their transplant.
And, you talk about semaglutide and there's a lot of excitement about some of the results that we're getting with medications like that some of the weight loss results are really impressive and far greater than what we've seen so far. But one of the other things that sometimes concerns me is that all these medication trials do incorporate dietary changes, behavioral changes, physical activity changes. And when you have something that's working well, do you have any concerns that providers will just prescribe the medication and miss some of those synergistic benefits of lifestyle changes?
Well, I actually think we have to reframe the whole discussion of lifestyle in general, because I think we should all live the healthiest lifestyle we can for the sake of the lifestyle, of health, of all the other benefits that lifestyle gives us, right? the mental benefits, the physical benefits of just feeling better, right? The fact that eating a whole food plant-based diet decreases your chances of cancers and Alzheimer's and other diseases. And we should reframe the discussion around lifestyle in that we should all move more because it's good for us. It helps our mental health. It helps our well-being. So we should reframe lifestyle because following a healthful lifestyle is good for us just no matter what our weight is. And we saw that even with some of the data around COVID-19, right? People who had a more healthful lifestyle, even if their weight was higher, were not as at high of a risk of being sick from COVID-19 because of their lifestyle. So lifestyle can be protective for various reasons. But unfortunately, lifestyle a lot of times doesn't produce a lot of weight loss. And so it's important as an additive benefit for all of these things in weight, but mostly because too, it's just really good for us for other reasons.
I think we have to look at those quality of life indicators. And that's something I talk to patients about all the time. It's not just how is the scale changing, but how is your quality of life improved? How is your sleep, your energy level, your mood, your pain levels, your perception of yourself? How has that changed with making those lifestyle changes? I think that's really important.
Yeah, that's the reason to have good nutrition and good sleep and decrease your stress and follow all these healthful lifestyle things, right? And again, they're hard to do in our world, which is the challenging piece because our current world is not aligned in that same way, sadly. So we have to build our own worlds, right? We have to build our own lifestyle and we have to own that, so to speak, and do the best we can with that. But we also have to recognize nobody's perfect. We can't be perfect. And we have to do things 80% of the time and recognize that there's going to be another 20% of the time where we might not be as healthful as we'd like to be, but that's okay. And being at that 80% is where we want to be, not that all or nothing mentality.
Right. I'll tell patients perfection is the enemy of good. That we are always striving to be perfect and it's an unattainable goal. And so that is something that we need to work with patients' perspectives on that because they do have that sort of black and white thinking that they struggle with.
And that's part of that shared decision making, right? And that expectation management and that, shared decision making is based on the idea that you're going to show people what the treatment options are, what's out there and what the expectations of each option is, and then help them come to a decision that fits into their level of engagement, their level of their life at the moment. Because life changes. It's a journey, and that's the challenges that we face.
And so you mentioned about bariatric surgery, and one of the things that I've noticed in some of the studies is, they compare bariatric surgery to medical therapy and showing bariatric surgery as being superior in most cases. However, we have newer medical treatments now that were not part of those studies. How do you think our current medical options compare to bariatric surgery now?
Well, our medical options are very exciting now, I think, and that's what the past 10 years of research and development in medicine has created, right? But we also have to help patients, again, in this expectation management to understand that there are these treatments for a reason. I mean, we don't come up with radiation, chemotherapy, and surgery for cancer because anybody wants those treatments. Nobody wants those treatments. Nobody wants cancer in the first place. But thank goodness that modern medicine came up with these treatments because now we can live longer, healthier lives without those diseases. And I think once we understand and really, really, really accept obesity as a disease, that we talk about it a lot, but we have to really accept that to be able to then say, these are the effective treatment options that we have. Because we have great medications today, and we have even more coming down the pike in the next 5 to 10 years, hopefully. And they're going to be producing results very similar to surgery. And so that's where it should be again, a combination, the title of my talk, Better Together, right? It should be all a combination of all of these things. Lifestyle, prescriptive nutritional interventions for some people, which might include a more prescriptive interventional lifestyle because it creates a certain outcome for that patient.
Yeah. And the other thing that I find is that there's sometimes is an either or kind of mentality, either using medications or doing bariatric surgery, right? And how do you see us in the future integrating those two before surgery, after surgery?
Yes, this is a very exciting time, I feel like, for our field because we're getting to that place. Again, I use that cancer analogy a lot, and I realize that obesity isn't cancer. They're very different life-threatening diseases in different ways. One that can sort of take your life very quickly, potentially with cancer treatment, and obesity, which takes potentially years off your life or quality of life years off your life in the long run. And so I think integrating these treatments is going to be key, just like it has been done with cancer. I'm sure eons ago, when all they had for cancer treatment was to cut it out, that's what they did. And then somebody said, hey, maybe we could shoot it with some radiation or give it some chemotherapy. And this is what we're into now with Dr. Ard's recent study looking at a combination of patients that were getting surgery and also combining that empirically, directly, right away, with chemotherapy, quote unquote, so to speak, which is our anti-obesity medications, in order to get a better result in the end. And that's where we're, I think, going to see that synergy, like we talk about, because it shouldn't be an either or. And it has been, as you mentioned, for such a long time, an either or.
And I like to use a cardiology analogy in that imagine we lived in the world of cardiovascular treatment where we ignored the blood pressure, ignored the lipids, ignored the diabetes until the patient had multivessel disease, then sent them for coronary bypass surgery and had the cardiothoracic surgeon manage the patient from that point on, right? And that doesn't make any sense, but that's kind of where we're at in the treatment of obesity, that we really need that continuum of care where it begins with primary care, doing early interventions with weight management, and then maybe managed by obesity medicine specialists for those more difficult cases, and then referred to surgery where appropriate. And then continued treatment with anti-obesity medications and obesity medicine specialist care. So creating that continuum, that would make a lot more sense than what we do now.
Completely and totally agree. In fact, one of the surgeons I worked with in the past, he was very passionate about this sort of idea that we needed to uncouple, so to speak, the treatment of obesity because it was so driven in the surgery world. And he's like, surgeons are surgeons. They take care of things. They go into surgery for a reason because they take care of very usually finite things that come and go. You have your appendix out and they take it out and they're done, and you don't really treat appendicitis as a chronic disease. That's what they should be doing is in the operating room performing what they're really good at, which is surgery. And I think the rest of it, should be integrated. But because there's this all or nothing mentality, that's what we have to and we have to help patients understand that too, because that gets driven by society, the societal feeling that this is something that we can treat by ourselves, obesity.
And I give a lot of credit to the surgeons because they've really worked very hard to improve quality of care. And one of the shortcomings of bariatric care years ago was the lack of follow-up. And they didn't really have any options. And I have to give them a lot of credit for building these options. But you're right. It's also they're doing this to fill a void, not because it's where their skill set is or even where they want to be, but they're doing it because there was a need. And I think as we can, continue to evolve and shift towards where we're both playing a role in a continuum of care, I think that would really be helpful.
That's, I think, huge. And that's just huge for obesity in general. And that's the sort of basis of the talk is that we're better together, right? And as we all work together, including the patient in that circle, we're going to see better outcomes in the long run.
Exactly. So I like to end with a question. When discussing obesity treatment with patients, what is your favorite bit of advice?
What is my favorite bit of advice? Well, I don't know. That's a good question because I have so many favorite bits of advice that I tend to follow myself, right? I mean, I went into this field and because I'm passionate about my own health and weight control and I feel like I learn things from patients every day too, so I like to get advice from them as well. I have my sort of 6 P's that I tend to give people as a pearl. So the P's stand for each of the titles of the little bits of pearl. So it's planned portions, plants and protein, power for exercise, pillow for sleeping well, and pause. I added the new one, pause, because that stands for the idea that we need to take a break, right? And pause between eating and mindful eating, right? It reminds us to eat mindfully. So those are a lot of P's. There's actually more than 6 of them there or 5 of them there, but I combined them together so I could get to 5 because there's 5 fingers on one hand.
Yes, that does simplify it. But those are great points. And I think that last one, mindfulness, it's such a missed but yet very important part of what we do with patient care.
Yeah, not only in eating and activity, but just in being mindful every day of everything, living in the moment and being in the moment so we can enjoy every bit of life we can.
Well, that's great advice. And thank you for being with us today. You can find more about Dr. Fitch's presentation in the OMA Academy. Her title of her presentation is Better Together: Combination Therapy for Optimal Obesity Management. Thank you for being with us, Angela.
Thank you, Nick. It's always a pleasure.
Thank you for listening to this episode of Obesity, a Disease. For more information about obesity medicine podcasts and other valuable resources from the clinical leaders in obesity medicine, please visit www.obesitymedicine.org/podcasts. If you enjoyed this episode and want to listen regularly, head over to iTunes where you can subscribe, rate, and leave us a much appreciated review. The views expressed in this episode are those of the host and guest and do not necessarily represent the opinions, beliefs, or policies of the Obesity Medicine Association or its members. Please join us again for our next episode of Obesity, a Disease.